Hello, everyone, and thanks for joining today's webinar, Demystifying 340B for Correctional Institutions. My name is Kara Skillingstead. I use she, her pronouns, and I'm the Correctional Health Program Coordinator for the National Hepatitis Corrections Network. For those of you who might be vision impaired or not able to see the video, I have brown hair, I'm wearing glasses, and I have on a light green shirt. As a reminder to participants, this webinar is being recorded. And because this is a Zoom webinar, all attendees are automatically muted. Throughout the webinar, please enter any questions you have for our presenters or panelists into the Q&A box for a moderated Q&A at the end of the session. And for any technical issues or assistance during the webinar, please send me, Kara Skillingstead, a private chat as I'll be monitoring our tech today. Next slide, please. This webinar is presented in partnership by the National Hepatitis Corrections Network, also known as the NHCN, and the National Viral Hepatitis Roundtable, also known as NVHR. Both NHCN and NVHR are operated by the Hepatitis Education Project. NHCN is a network of people with an interest in viral hepatitis in correctional settings. NHCN supports a public health approach to hepatitis prevention, testing, treatment, linkage to care, and harm reduction education in prisons and jails. Network partners include correctional administrators and healthcare providers, researchers, legal and policy stakeholders, community-based organizations, and health educators. The NHCN tracks broad trends in viral hepatitis prevention, testing, and treatment in U.S. prisons and jails, develops and produces educational materials for incarcerated people about hepatitis, and connects network partners to each other through regular email communication, newsletters, webinars, and an in-person annual meeting. It's now my pleasure to introduce the moderator for today's webinar, Dr. Adrienne Simmons. Adrienne is a pharmacist who has experience with 340B in the hospital setting. Adrienne is the Director of Programs at the National Viral Hepatitis Roundtable, and I'll now hand it over to her to tell us a bit more about NVHR and what they do.
Thank you so much, Kara. As Kara stated, my name is Adrienne Simmons. I use she, her pronouns, and I'm excited to serve as the moderator for today's session. For those of you who aren't familiar with the National Viral Hepatitis Roundtable, we're a coalition of patients, healthcare providers, community-based organizations, and public health partners whose mission is to eliminate viral hepatitis in the United States and to improve the lives of those affected through advocacy, education, and support to our national, state, and local partners. NVHR aims to support an integrated response to the viral hepatitis epidemic by centering the voices of people with lived experience, fighting for equitable access to viral hepatitis prevention and care, and advocating for fully funded state and federal elimination plans. Today's webinar will include a didactic overview of the 340B program, followed by an expert panel and Q&A, who will discuss the use of 340B in correctional institutions. Attendees are encouraged to ask questions using the Q&A function at any point during the webinar. We'll conclude today's webinar by sharing upcoming opportunities to engage with NHCN and NVHR. Joining us today to provide an overview of the 340B program and to highlight key issues and considerations are Emily McCloskey and Jeff Davis. Emily McCloskey is the Director of Policy and Legislative Affairs at NASDAD, an organization that represents the chief public health officials who work on HIV and hepatitis. In her role, Emily provides strategic leadership and develops innovative policy solutions to advance the legislative and regulatory policy priorities related to HIV and hepatitis. Jeff Davis is of counsel and senior advisor at Baker Donaldson. In his role, Jeff advises healthcare providers and other clients on legal and policy matters, including assistance with the complex issues surrounding the 340B drug pricing program, as well as Medicare and Medicaid billing and reimbursement issues. At this time, I'd like to turn it over to Emily to provide an overview of the 340B program.
Thank you, Adrienne, and thank you so much for having me. It's really a pleasure. Next slide. So today I'm going to start off by talking about what exactly 340B is. So first and foremost, the 340B program is a drug pricing program. It was created in 1992, and it requires drug manufacturers to provide outpatient drugs to eligible healthcare organizations and covered entities at significantly reduced prices. It was enacted by Congress and signed into law by George W. Bush. Eligibility is dependent upon receiving federal funds that are authorized by certain sections in the Public Health Service Act. It is administered by the Health Resources and Services Administration, or HRSA, and in the Office of Pharmacy Affairs, or OPA. And the purpose of the program is to stretch scarce federal resources as far as possible, reaching more eligible patients and providing a more comprehensive services. Next slide. So the 340B drug pricing program is very large. I think this group is probably most familiar with the aspects of hospitals and health departments, which we are going to talk about, but it's much bigger than that. While the bulk of those enrolled in the 340B drug pricing program are hospitals, including critical access hospitals, disproportionate share hospitals, children's hospitals, freestanding cancer hospitals, and sole community hospitals, there's also other grantees. So federally qualified health centers, Ryan White providers, Title X family planning providers, hemophilia clinics, STD clinics, which is also known as Section 318 grantees, and those include viral hepatitis programs, HIV programs, and STD programs, and TB clinics. So about a third of all U.S. hospitals participate in the 340B program, and almost all grantees that I just listed participate in some way. And for viral hepatitis programs in particular, they fall under the federal grantee STD clinic category. So correctional institutions primarily access the 340B discounts via two pathways: one, a hospital partnership, or two, as an STD subgrantee. Next slide. So enrolling in the 340B program gives you access to deeply discounted medications. And we're going to talk in more detail about that. But I wanted to sort of say 340B is not a funding source. It does not give out medications for free. It doesn't pay for testing or lab support, and it is not used for vaccines. So only outpatient medications are allowed to be purchased utilizing the 340B program, and vaccines are strictly prohibited. Medication can be dispensed to patients or administered on site, which I think would be happening here, and those activities are considered outpatient. Everyone who's enrolled in the 340B program must still adhere to your state pharmacy rules. So that sort of has to do with some other issues on contract pharmacies that we will be discussing. And so we can go to the next slide. So medications cost money, pretty obviously. So the required discount for the 340B drug is either 13% on generics or 23.1% on brand name drugs from the average manufacturer price. There are sometimes additional discounts required if the drug manufacturer has chosen to increase the drug's price or offer a lower price to purchasers. They can also voluntarily provide additional discounts. So, for example, there's a Medicaid price. There's lots of different drug prices in general. There's a Medicaid price, a 340B price, a wholesale price, a retail price, a group purchasing price, and when depending on the program, you're able to access different levels of that. But we are going to focus on the 340B price, which is specifically that 13% or 23.1%. So we can go to the next slide. So now that we've talked a little bit about what the program is and is not, we can talk about who can utilize the program. So to become a 340B covered entity, you need a qualifying provider and to serve qualifying patients. A 340B qualifying provider receives qualifying funding, so is one of those grantees that I said before, or support that comes from a federal funding source authorized by the Public Health Service Act. The qualifying provider may be a grantee, receiving their funding straight from the federal government, such as the state health department or subgrantee, somebody who receives a pass-through through federal funds from the state health department, such as a local health department, local clinic, or community-based organization, or someone who's contracting with the state health department. So in this case, you can become a qualifying provider if you are receiving funding or an in-kind donation, which we will talk a little bit about. So that's how you can become a qualifying provider, even if you're not receiving funds directly from the federal government as part of the Public Health Service Act. So to become this qualifying provider, you also have to register in the 340B database, complete an annual recertification, and comply with the 340B program requirements. Next slide. So we're going to talk a bit about patient definition. So this is a pretty wordy slide, but To be eligible to receive 340B medications, patients must receive healthcare services other than drugs from the 340B covered entity. So patient eligibility has these three parts, and an individual is not considered to be a patient of the covered entity if the only healthcare service received by that person is the dispensing of the drug. Once the 340B patient definition is met, 340B can cover any outpatient prescription that is warranted by the visit or is clinically indicated. So that means that you, in this case, and we're going to talk about that in our next scenario, but it means that you need to do something other than just dispensing the drug. Now, in a corrections facility, that is likely to be happening, but we'll talk about a good example of what that could be. And just as a reminder, vaccines are not covered, even though I think they are quite the hot topic of today. Next slide. So I'm going to use this example and talk about how this could work with a correctional facility. So La La Land Correctional Facility houses 3,000 incarcerated individuals. The facility is responsible for the medical care of their population and has medical charts for everyone. The facility has an MOU or Memorandum of Understanding with the State Health Department, is participating in a microelimination project, and receives rapid HCV tests from their State Health Department, all funded through PS 21-2103. That would be one of the sub-grantees. PS 20-2103 is a grant that comes under the 318 grant. Every incarcerated individual is tested for HCV antibodies upon arrival, contributing to the detection, investigation, and control of HCV, as well as increasing access to testing, prevention, and treatment services. So part one of the patient definition is met here because the covered entity clearly has established a relationship with individuals and maintains records of those individual healthcare. Part two is met because the incarcerated individual receives their healthcare services from an employee or a paid contractor of La La Land Correctional Facility, and they maintain the responsibility of their care. And part three is met because the individual receives healthcare services from the covered entity, which is consistent with the service or range of services for which the grant funding has been provided to the entity. So in this example, incarcerated individuals are screened for HCV antibodies upon arrival at the facility, and they are achieving the goals and the purpose of the grant, which is so in this particular instance, the correctional facility is a subgrantee and is receiving both funding and in-kind contributions. All of this is formalized and outlined in an MOU between the State Health Department and La La Land Correctional Facility, and policy and procedures are in place, serving as an audible record. If La La Land Correctional Facility wasn't testing everyone for HCV upon arrival, which I think is the case in many places, it would be up to the health department to ascertain what activities La La Land Correctional Facility was doing that were consistent with the service or range of services for which the grant funding has been provided to the entity. I saw a question, which is if the patient has a social security number, are they eligible for 340B? And 340B does not require a social security number, so you don't need, has no insurance but has it. So the patient definition is really what defines it. It's okay if they have some form of insurance or none, or if they do not or do have a social security number. Next slide. So all health departments who receive CDC funding authorized by Section 318 of the Public Health Service Act are eligible for the 340B program. And so that means their subgrantees are also eligible. Covered entities must have this financial relationship with a qualifying Section 318 program that makes them eligible for 340B, and that can be in direct financial support or in-kind contributions. So the in-kind contribution definition is pretty vague, which is something you should use to your benefit. Not all programs are the same, and in-kind contributions vary from program to program. So you can see here the definition of what in-kind contribution are. So in-kind contributions that come from viral hepatitis programs might look like laboratory payments on behalf of the organization for HCV confirmatory testing or courier fees to transport specimens to the laboratory for hepatitis testing. It could also be something like HCV tests, medical supplies for HCV testing or treatment, syringe disposal services, educational materials. So there's a lot of different options of ways that you can make this happen. Whatever the in-kind contribution is, it must be purchased with the qualifying Section 318 funding. So this would mean that the health department would actually purchase the test and then give them to the correctional facility, and that would be the in-kind contribution. It's usually, though, there is a memorandum of understanding or agreement that comes with that makes it easier for auditing. Next slide. So the 340B program provides upfront savings by giving covered entities access to deeply discounted medications. We're going to go back to La La Land Correctional Facility. So in this instance, they're now able to stretch their medical budget further, providing hepatitis C treatment to 50 individuals a year instead of 5. They've also saved $800,000 in HIV medication costs and are able to provide PrEP to folks leaving the facility. So, by being so fiscally responsible, they've also won this award from their governor's Office of Budget and Management for being healthcare heroes. So we know that the 340B program can do a lot. It allows covered entities to generate revenue if they have insured patients. This is done by dispensing a 340B priced medication and billing insurance for the medication. The insurance would pay the retail or negotiated health plan price, allowing the covered entity to generate that revenue. So that can, that's how we can see the stretch in the federal resources as well. Grantees, including subgrantees, are required to use all 340B revenue and savings for activities that promote the purpose of their qualifying federal funding or federal grant. So if you are seeing savings or revenue from your 340B program, you must be putting it back into providing care. You can't use it for something like building a building or increasing salaries. It has to be going back into care. And so I'm now going to turn it over to Jeff, who is going to talk about some other 340B issues.
Thank you so much, Emily. So, in the next few slides, I wanted to dig a little deeper beyond the really helpful overview that Emily provided to go through some of the key issues and considerations that correctional facilities may want to keep in mind as they're evaluating if and how they can participate in the 340B program. And so in this section, I want to break this up into 3 different areas. We'll talk about some key eligibility issues, some key compliance related issues, and then I do want to spend a few minutes talking about some operational issues and some of the real key developments that have taken place over the last few months that have created some operational challenges in the 340B program space that may limit a provider's ability to access revenue through the 340B program. And we'll talk a little bit about some of the advocacy that's taking place in this space. So if we go to the next slide, we can start off focusing on some of the eligibility issues. And Emily, did a great job of sort of highlighting, from a correctional facility perspective, it's often thought of as really there are 2 different avenues for the possibility of in some way being a part of 340B participation, one indirectly, one directly. Indirectly through partnership with the hospital and directly as an STD clinic that is participating in its own right as a 340B covered entity. And there are particular challenges that come with both avenues. On the hospital side, the correctional facility itself is not the covered entity that qualifies for and is participating in the 340B program. It is the hospital that is the covered entity. So the hospital has compliance obligations that go along with that. And if a hospital is interested in discussing with a correctional facility whether there's an opportunity for a partnership to be able to use 340B drugs purchased by the hospital for prescriptions that were written in the correctional facility, there are certainly compliance issues that go along with that I think are really important for the hospital to think through. Because a lot of those challenges, often we do see correctional facilities think through whether they may be able to participate in their own right as a 340B covered entity. And as Emily mentioned, often this is through the STD clinic category, either as a direct recipient or a sub-recipient of Section 318 grant funding from the CDC related to STDs and STIs. This particular category can often have its own challenges that come along with it. And I did want to emphasize that there has been somewhat of an increase in scrutiny by HRSA, the Health Resources and Services Administration. That's the agency that administers the 340B program. They've started to pay a little bit more attention to this eligibility category. So in July of last year, HRSA put forward a program update, which they often do on a monthly basis, with some changes to the registration and annual recertification requirements. Registration is one time when the entity submits its application to enroll in the program, but all covered entities that participate in the program on an annual basis once a year must undergo an annual recertification process, where essentially they verify that all of their registration information continues to be up to date, that the entity continues to be eligible for the program. In the past, there's not much that HRSA has collected either during registration or recertification to verify that an entity that is participating in the 340B program as an STD grant recipient, in fact, has received grant funding or some other sort of in-kind support. That has changed, and HRSA has made clear that during the registration process, they're going to ask for the notice of funding opportunity, they're going to ask for the date range of the funding, and if the entity is attempting to enroll in 340B because they've received in-kind support from the direct recipient of the grant funding, and as Emily mentioned, that could be in-kind support through supplies or through covering particular costs. Often we see this with either HCV or HIV testing kits, that type of support does need to be identified and what the support is as part of the registration process, which was not really previously required. And this information is going to need to be updated during the next recertification process. I think historically STD clinic recertification has been in the May-June timeframe. I don't believe I've seen dates yet as to when this year's recertification will take place. So I just wanted to flag this as a new area where HRSA is paying attention kind of at the onset before we even talk about compliance requirements, but just to make sure that the entity is in fact eligible to participate in the program in the first place. So if we go to the next slide, we can shift a little bit more to the compliance requirements. Once an entity is in the program, they've qualified, they've enrolled, they're participating. And I wanted to dig a little bit deeper about one of the specific prongs of the patient definition test that Emily mentioned, because this is or can be one of the key challenges which certainly I think would apply in the correctional facility space. As Emily mentioned, there is a requirement in the 340B law that is referred to as the prohibition against diversion, that says a 340B covered entity may not transfer or resell a 340B purchased drug to an individual who is not a patient of the covered entity. And HRSA has issued guidance, which is essentially a 3-part test for an individual to be deemed a 340B eligible patient. And it is worth noting, and this does relate to the question that we received from a participant earlier, and I think it's a really great question and worth taking a moment to highlight that there's often confusion and perhaps and sometimes even a misunderstanding that 340B is in fact a patient benefit, so the individual needs to qualify to be able to receive the benefit of 340B, and often that's why sometimes people think, oh, it must be that the individual is uninsured in order to qualify as a 340B patient. But in fact, 340B is actually not a patient benefit program. It's really a provider or entity benefit program, in recognition of the fact that a particular healthcare provider that is writing prescriptions for patients may serve a high volume of low income or otherwise vulnerable or underserved patients. That type of provider is given the ability to fill prescriptions for drugs at those reduced 340B prices. And to the extent that they're billing insurance for those drugs and able to bring in reimbursement, that generates the financial benefit. And the idea is that the financial resources, the benefit, is then able to be invested in care for low-income, vulnerable patient populations. And so that means that the individual does not have to be low income or uninsured to qualify as a, quote, 340B eligible patient. Commercially insured patients, individuals who are higher income, they can qualify to receive 340B drugs if, in fact, they meet this three-part test in the patient definition guidance. And that allows the covered entity to generate 340B dollars by using a 340B drug for that patient. So with that background in mind, the third bullet or third prong of the patient definition test, which applies specifically to those that qualify in 340B as a grant recipient. So this does not apply to hospitals, but for those that participate as grant recipients, like an STD clinic, they do have to verify that the individual received healthcare services that are consistent with or within the scope of the services for which the grant funding was provided. This is something that the auditors would certainly look at when HRSA conducts audits of covered entities, because it's sort of kind of a threshold issue. If there's no nexus or connection between the entity using the in-kind support from the STD grant recipient or the funding received through the STD grant, if there's no nexus between that and the individual, then the individual is not able to receive a 340B drug. And this can become especially complicated if we're talking about individuals that maybe did receive a service that's within the scope of the grant, but perhaps there are prescriptions written for that individual that are unrelated to the scope of the grant, and that can happen in some cases. And then there's a challenge as to whether those particular prescriptions can qualify for 340B or not. There's limited written guidance from the agency on this point, but there is some guidance, and ultimately I think it is expected that that patient definition and a particular entity's policy for when an individual qualifies to receive a 340B drug or not, that should all be addressed in written 340B policies and procedures that are implemented and put in place at the onset when the entity first begins participating in the 340B program. And those policies and procedures are really important because when auditors come in to evaluate compliance, they audit against the policies and procedures. And certainly they need to be consistent with HRSA guidance, but they are also making sure that you're following what you said you were going to do in your policies and procedures. On the next slide, I won't spend too much time on this. Whether it applies in the correctional facility space may depend on the scope of your Medicaid population. And correctional facilities may be, filling scripts for patients as they're transitioning out back into the community that may be in fact on the Medicaid rolls. And the intersection between 340B and Medicaid is very complicated, and there are compliance requirements that are associated with it. State Medicaid agencies often put specific billing and reimbursement requirements in place when it comes to filling a prescription for an individual that is covered by Medicaid. Often these requirements stem from federal law that says manufacturers are protected from a duplicate discount. They should not have to pay 2 discounts on the same drug. And that means they shouldn't have to sell a drug at a 340B price to the covered entity and also have to pay a rebate to the state Medicaid agency on the back end for the same drug. And so often there are rules put in place in terms of a covered entity's ability to use 340B drugs for a Medicaid population. If they are able to use 340B drugs, whether they need to include a modifier to identify the drug as being purchased at a 340B price, and in some cases, the amount at which you can bill for the drug, and of course, how much you will be paid for the drug. And complicating matters even further, these policies often are different with respect to traditional Medicaid fee-for-service programs versus drugs that are billed to a Medicaid managed care organization. So again, whether or not this is applicable in the correctional space, depends on a particular payer mix and if you have Medicaid coverage or not. But if you do, this is certainly an area to focus on because it does come up in the context of HRSA audits when they are evaluating compliance under the program. On the next slide, I wanted to sort of address this third category of issues, which are kind of operational challenges and some of the key recent developments that may affect your decision whether to participate in 340B, and I think are just important to be on your radar for those that are in 340B currently or are considering participating in 340B, because there are some pretty big issues going on that, depending on how they are or are not addressed, may affect the ability for covered entities in the future to generate significant revenue or benefit through the program. I want to first focus on an issue with the 340B contract pharmacy model, which is very instrumental for many types of entities in their ability to generate a financial benefit through the 340B program. And I think this is especially true in the correctional facility space, certainly for entities that do not have their own pharmacies. Often they rely on a contract pharmacy model to be able to fill prescriptions at 340B pricing and generate that financial benefit. So I thought I'd just take a moment to go through what this model looks like and how it may or may not be helpful, and then we can talk about the challenges that we're facing in this space. Often when I think about the 340B program and the ability for a healthcare provider to access the 340B financial benefit, we think of maybe 3 different settings or ways potentially that a provider could use 340B drugs to generate the financial benefit. One would be if there are outpatient clinic areas where you're administering drugs, infusion products, injected, implanted products. This is often certainly in the hospital space, in outpatient clinics where there's a lot of infusion or chemotherapy taking place in the emergency department. That's one opportunity to buy drugs at 340B prices, use them for 340B eligible patients. The second would be in the retail space if a covered entity owns its own retail pharmacy where prescriptions are filled over the counter, whether it be in person or mail. That would be an opportunity for the covered entity to directly purchase 340B drugs to be dispensed through their own pharmacy to their own 340B eligible patients. The third potential setting is through the contract pharmacy setting. And this is an option whether a covered entity has its own pharmacy or not, but especially if an entity does not have its own pharmacy, and if an entity is not administering drugs on site. For that type of entity, the only ability to access the 340B benefit would be to write prescriptions for their patients, have those prescriptions filled through pharmacies in the community that are under contract with the covered entity through a 340B contract pharmacy arrangement. And through this model, the 340B covered entity orders 340B drugs to be shipped directly to the contract pharmacy location. And the contract pharmacy dispenses those 340B drugs on the covered entity's behalf to the covered entity's patients. Bills the insurance company, reimbursement that comes in goes back to the covered entity. Certainly the pharmacy will often keep a dispensing fee for itself, but this is an opportunity to generate those financial savings or revenue to go back to the covered entity, and it's done through this contract pharmacy model. And there are a number of different types of pharmacies that could potentially serve as a contract pharmacy. It could be a chain pharmacy, it could be an independent pharmacy. In the context of integrated health systems, it could be a system-owned pharmacy. The idea being that the pharmacy is a separate legal entity from the covered entity. If the covered entity owns the pharmacy itself, it operates as an entity-owned or in-house pharmacy, not as a contract pharmacy. So with this background in mind, if we go to the next slide, I can go through some of the challenges that we're facing right now in this space. Starting last summer, we've seen at this point, I believe now 6 drug manufacturers that have begun to deny 340B pricing for drugs that are dispensed through contract pharmacies. For many years, drug manufacturers have honored these requests for 340B pricing. If a covered entity placed an order for a 340B drug through its wholesaler, whether that drug was to be shipped directly to the covered entity or to the contract pharmacy, manufacturers honored those requests. But the recent trend among some manufacturers is to not honor the 340B pricing if the drug is to be shipped directly to the contract pharmacy. Some manufacturers are taking the position that the 340B law does not require them to make 340B pricing available for drugs dispensed through contract pharmacies. Providers, on the other hand, are arguing that no, the law does not allow a manufacturer to pick and choose when 340B pricing should be honored versus when it should not be honored. It's a must offer provision. The statute says that the manufacturer must offer the 340B price if a covered entity is placing an order for an eligible covered outpatient drug. And so this is a dispute that is now taking place between some manufacturers and covered entities. There's been a lot of advocacy in this space, including litigation, as well as getting members of Congress involved. The request from providers has been for HHS to weigh in on this and to actually enforce the statute and take action against manufacturers that are violating the law. And HHS does have the ability to impose civil monetary penalties against manufacturers that are overcharging a 340B covered entity. There's been some lawsuits filed by providers urging HHS to take action. We did see action from HHS late last year. At the end of the last administration in late December, the HHS General Counsel did issue an advisory opinion that does say the 340B statute requires manufacturers to make 340B pricing available, including for drugs dispensed through contract pharmacies. And that was a great first step. But at this point, HHS has not enforced that advisory opinion. They've not taken any enforcement action or penalized any manufacturers that are not following that advisory opinion, not following the 340B statute. And so providers are continuing to push for HHS to take that action. Many members of Congress have weighed in to HHS. Meanwhile, drug manufacturers have filed lawsuits challenging the advisory opinion because they do not believe the law requires them to make the discounted prices available for the contract pharmacy setting. And then the added development or wrinkle in this space has been the implementation of a 340B dispute resolution process, which is an opportunity for manufacturers and covered entities to file a claim with the government to allege that the other stakeholder has violated a term of the 340B program, and for that claim to be heard by a panel of HHS employees for them to issue a binding decision. And HHS has taken the position that if a covered entity believes that they've been overcharged by a manufacturer because the manufacturer is denying this pricing, they can file a claim through the ADR process. I think a number of other providers have said this is not going to be a timely solution to this problem. We really need immediate enforcement action. And the latest development in this space is that one federal court in Indiana has actually placed a temporary injunction on implementation of the dispute resolution process with respect to one manufacturer because there may be a strong likelihood that the government did not follow the proper procedures in implementing the dispute resolution process. So I think that raises some questions as to whether what the future of the dispute resolution process will be. So that is another kind of key issue on the table for stakeholders to pay attention to in terms of how and if HHS moves forward with implementation of the dispute resolution process. But the final note I'll just mention here before I wrap up, from a practical kind of takeaway perspective, is that for those that are in the 340B space or considering whether to get in the 340B space, it is worth monitoring what goes on here, because to the extent that you're planning on writing prescriptions for drugs and expecting to be able to fill those drugs at 340B pricing through a contract pharmacy, really making sure that that opportunity is going to be there, because that really is inherent in the ability to generate that financial benefit. And in light of the actions from at least 6 manufacturers so far, there are questions as to what the future of this contract pharmacy model might look like. And although it's only 6 manufacturers right now, certainly depending on the outcome of some of these legal actions and HHS enforcement, we could see other manufacturers choosing or not choosing to follow the lead of these 6 manufacturers. So that's just at a real high level some of the key issues that I think are worth keeping in mind kind of from an operational perspective, in addition to the eligibility and the compliance issues. As you can see, this is a very complicated program, certainly one that there's a lot of value to in terms of the potential to access those financial resources, but also some compliance considerations and operational challenges that can come along with that. I know we've got a panel of some great speakers who have probably some practical tips, far better than I could be able to share in terms of how to navigate through those challenges. So with that, I will turn things back to Adrian, and I think we'll be moving forward with some questions from our panel.
Awesome. Thank you so much, Jeff. Pictured on the screen here is the contact information for both Emily and Jeff in case anyone would like to follow up with them directly with questions. And this is being recorded, so you'll have access to this later as well. At this time, we will transition to our expert Q&A. I will invite all of our panelists to join me on video, and I'm going to stop sharing my screen. We'll give folks just a minute to get situated. Wonderful. So joining Emily and Jeff, we have 3 additional wonderful panelists today, Dr. Robert Lawrence, Dr. Pauline Markison, and Dr. Brandon Sith. And so to kick off our panel, I will just ask that each of you please introduce yourselves and how you personally have engaged with the 340B program. Before I transition to introductions, I did just want to say that please continue to submit your questions via the Q&A function. I believe that Jeff has answered both of the questions that were submitted, but certainly if you all have lingering questions, don't hesitate to follow up on those. And if any of the other panelists would like to comment on those questions, you're welcome to. But to start, let's start out with some introductions, and then we'll get into some questions. Pauline, would you like to start?
Sure thing. Pauline Markison, I'm the Administrator for Healthcare Services here at the Rhode Island Department of Corrections. We've been a STD grantee for about 18 months, and we did a little bit of investigating before we jumped into that whole project for about 6 to 8 months beforehand. So we've been really lucky and have saved some substantial money in treating some of our Hep C patients, HIV patients, and others. So thanks for having me.
Great, thank you. Robert?
Hi, thanks, Dr. Simmons, and good morning or afternoon to everyone. My name is Robert Lawrence. I'm the Chief Medical Officer for the Alaska Department of Corrections, and like Dr. Markinson, probably here on the panel to help answer that question of how do you speak to people like us who are in administrative positions when you recognize the overwhelming need represented by hepatitis C, HIV, and some of the other things that we treat, but recognize, as Jeff Davis was just saying, just how complex paying for this care and organizing this care is. So hope to at least be available to help answer how do you speak to people like us and pull together the right entities.
Thank you so much. Brandon?
Yes, hi. Brandon Siss. I'm a pharmacist with the MCAP Infuse organization. It's run by the state of Minnesota. We offer contracts and procurement opportunities to city, county, and state facilities all across the country. One of those being wholesaler contracts that do offer sending these 340B pricing options through to our members. And we've also been in assistance with getting some of those contracts set up with outside pharmacies.
Wonderful. Thank you so much. So as you all can see, we've got a diverse group of panelists here, and we hope to be able to answer any questions that you all may have, whether they're higher level kind of policy questions or more in the weeds practical questions about how you might go about implementing the 340B program, or how you should be thinking about the 340B program in your institution. And so to start us off, I'll start off with kind of a broad question, and I'll direct this first one to Emily and Jeff, but certainly any of the panelists are welcome to chime in. We talked a little bit about the various pathways by which correctional institutions may access 340B discounts, one being partnering with a hospital and the other being an STD subgrantee. What considerations or advice would you have for correctional institutions in terms of deciding which pathway to take?
This is Jeff. I'm happy to take that first, and I'm sure Emily might have some thoughts as well. You know, one consideration that I think is really worth kind of thinking at the top is the key difference being if you collaborate with a hospital, you are not the 340B participant directly, the hospital is. Whereas if you enroll in 340B as an STD clinic grant recipient, you're directly the 340B covered entity. Now, there may be pros and cons to both approaches. You know, if you're the direct covered entity, you're responsible for compliance. You're on the line for compliance issues that may occur. On the other hand, if the goal is to generate financial resources, that your ability may be limited if you're partnering with a hospital that is the covered entity and you're not the covered entity directly. You know, the other thought that I would share, and this is coming more from the hospital's perspective in terms of whether they're willing to enter into a collaboration, there can be some really key compliance considerations for the hospital as to whether that is an option for them. The patient definition test for the hospital would say that they can only use 340B drugs for individuals who are patients of the hospital. And so the question is, depending on the relationship between the hospital and the correctional facility, whether an individual who's written a prescription at the correctional facility is in fact a 340B eligible patient of the hospital. And that can be a complex analysis as to whether that statutory requirement is being met or not. So certainly some really key compliance considerations there that are worth keeping in mind as to whether a collaboration like that would even be possible.
Thanks, Jeff. Sorry about that. Everyone, my internet decided to go unstable. But I'm glad that Jeff could provide such a great answer to the question.
Awesome, thank you both. We've had a couple of questions come in through the Q&A function as well. I'm gonna go ahead and pose one of them to the group before we get into some more specific questions. And that question is, Can someone comment on regulations around guiding a patient to use a 340B pharmacy? Can you limit where someone fills their prescription?
The answer is no, you cannot. That's sort of a general hallmark under kind of a number of different federal laws in terms of, you're implicating, fraud and abuse and, inducing patients to use particular pharmacies. That's always a consideration that, should be kept in mind. In the 340B program specifically, in the context of the 340B contract pharmacy model, one of the key elements that HRSA expects be addressed in a contract pharmacy arrangement, and they do expect that there be a written contract in place between the covered entity and the contract pharmacy. But one of the elements they expect to be included is a provision that says that the patient has freedom of choice, that they are able to use the pharmacy of their choice. Now, if they use that contract pharmacy, that may generate the 340B opportunity, but HRSA would expect that there not be a requirement that a patient use a particular pharmacy.
I guess as a side note to that, in corrections, you're often limited to whatever pharmacy the correctional institution is using. If it's being used for an incarcerated patient, if the patient is released, obviously it's a different ballgame. You can go to any pharmacy if you're choosing, but if you're incarcerated, you're limited to where the correctional facility fills its prescriptions.
And that is an important, I think, specific sort of circumstance with respect to the correctional facility setting that may not apply in more traditional healthcare settings. The other being also payer restrictions too. I mean, sometimes payers do certainly put restrictions on which pharmacies are in network. That's a payer, requirement, not necessarily the provider requirement. So those are, that is an important point as well.
Building on that, are there other special considerations that might be unique to correctional facilities as it relates to the 340B program that we'd like to highlight for folks here? Any unique challenges that a correctional facility might experience, but another 340B covered entity may not?
I'll jump in there. One of the unique challenges that we face is the actual tracking of every single script and every unit dose card that comes in. We move patients from facility to facility. So a lot of times those, not that the cards ever get lost, but it's just a matter of tracking the number of doses still left on the card. And it's our 340B coordinator who has to actually account for every single medication. So that's one of the challenges, especially if you have a very large correctional facility, that could be a little bit cumbersome, but it's just a matter of pulling together a team and making sure that you can follow through on all of those. That's one of our challenges here.
And I think that's a great question, because I'm envisioning that some of you who are attending are working within a correctional setting, and then some of you may be in more of a public health setting or even working in a community STD clinic, and you just recognize that there is a concentration of the problem you're trying to address, in this case, hepatitis C, in the correctional setting. In other words, in the community, Hep C represents about 1%. Prevalence in the community. But when you come into the correctional setting, when you walk into a prison or a jail, that number can jump up to 30% really fast. And especially among persons who inject drugs, 45% of those individuals can be active with Hep C. So one of the challenge is on the correction side is just recognizing the problem, I think, that everyone recognizes who is a 340B entity, but recognizing that in corrections, that problem is concentrated. However, and here's the challenge, your correctional institutions are not set up primarily as healthcare institutions. They are set up for public safety. And so this is a very important point. The prison is not an STD clinic. It is not set up as a hospital or an outpatient clinic. We are statutorily, constitutionally required to make sure everyone who lives there gets essential health care. And that includes the treatment of Hep C as well as everything else. So I would say one of the huge challenges, especially on the implementation side, is recognizing the overwhelming burden of all healthcare issues that are concentrated within the correction setting. How do you set aside the time to get your arms around a really complex opportunity, which 340B offers, and be assured that that is time well spent. In other words, that if we're going to take the time to put together the policies and the procedures and make sure that we're doing it right and could make our way through an audit and that it meets the not only the letter of the law but the spirit of this whole statute. How do we get to the end of that and be assured from the start that the money spent today is going to save millions of dollars down the road? And I think that's the point, in Alaska that we got to of saying, okay, this is something we should pursue. But I would present that as a challenge to know going in that the 340B issue is not a quick solution to a minor problem. This is a great part of a solution, but it's really to a huge problem that is concentrated in the shadows of our prison setting that is not seen by the public. So it's really hard to generate that public and political will to move forward.
Thank you so much. I want to continue building on the practical aspects of this, and I think this question is directed to Pauline and Robert. But can you tell us what it's like to be an STD subgrantee? You can expound upon the challenges that you've encountered. Maybe tell us a little bit about what additional services the 340B program has allowed you to provide in your facility. And then lastly, there was a question that came through the chat regarding having received conflicting information about what care can actually be covered under 340B, whether it can include other medications once they are established to be an eligible patient, and specifically in the context of being an STD subgrantee, can you expound upon and provide a little bit of guidance about whether hepatitis C treatment can be covered due to the limited ability to confirm whether it was contracted sexually via sexual transmission? So a larger question here, and feel free to chime in on any aspect of that. And certainly if any of the other panelists would like to chime in, please do.
Well, Dr. Markson may be able to give more details. Rhode Island is a great example of how to do this right. I would just say from Alaska's perspective, when addressing the first question, which was what is it like to be in one of these, to be an STD program subgrantee, I would say that that's not just a question of what is it like, should we establish that relationship? To me, that's really the key component to all of this. And it's really either the easiest part of participating in the 340B program or maybe the hardest. And it all depends in your state about whether or not there's already an established relationship, a close relationship between correctional healthcare entity and the local public health STD program. In our case, that relationship was already well established. We were already for years have been receiving services in kind and had worked closely with our STD prevention program, so that when the question about how are we going to pay for hepatitis C medicines came up, and then the 340B program came to light, which has been around since the 1990s. I mean, it was just recently that we recognized maybe this is something we could participate in. When all of that came to light, it ended up just being a phone call to a friend that we had already worked with for years. And my point in saying that is to say that really, even before you get to all the questions of policies and procedures on 340B, if the path that you plan to take is this subgrantee path, the very first relationship to establish is that relationship between public health STD prevention program and the correctional institution, and work on that relationship and make sure that going forward, it's in lockstep together so that every decision is a we decision and not just one department or another.
Dr. Lawrence, I tend to agree with you completely. We have a very strong relationship with our Rhode Island Department of Health, and that's how we became an STD subgrantee. And the nice thing about it was it's a small state, so we all know each other. We also have a very strong public health team here at the Department of Corrections. People step in and out of those lanes rather easily, but that has helped us foster that relationship. What we've done differently is we actually register every patient that we think are going to need Hep C treatment, HIV treatment upon commitment. So they go through probably about 20 questions. We offer them STD testing. The Department of Health does that testing for us. So we do that in kind. We get test kits in kind. And then from there, we've put together this other team of folks that actually look at FibroScan results, diagnostic testing, and they start working with the patients individually to see what kind of treatment will work for them, because not every medication works for every person. We're also under the direction of a real young and energetic new medical director who's got some great ideas, Dr. Justin Burke. And he's also looking at expanding how we can provide more services to those that are enrolled in the STI clinic. One of the questions you posed was, how broad can we offer medications? We still struggle with that. Right now, we're just doing Hep C, HIV, biologics, but we're weighing in. We really want to look at the regulations again to see if can we expand it to diabetic meds. We're really not sure, and I would probably refer that part of the question to Jeff, who knows those policies. He actually helped us. If anybody wants to know, I would suggest that before you start looking at jumping in and doing a deep dive, you talk to a very good attorney group that has experience working with 340B. If you don't, you're just going to go down a rabbit hole. It's going to be real difficult to get out of. But we were fortunate. We developed all of our policies based on some real hard work with Jeff and his group. So I hope that helps.
Jeff, would you like to chime in?
Sure, and thank you for those kind words, Pauline. I'm particularly interested in Emily's thoughts on this question. There's a patient definition question here, and often the associations have good insights into where the guidance is, where the agency is going. The answer is not a clear one here. And so for anyone who really is interested in sort of exploring this question further, certainly happy to chat offline, because kind of it depends on the facts and circumstances. And, I'm not here to give legal advice, of course, but sort of generally speaking, the question that I think that some are identifying is if an individual is treated in the correctional facility setting and has received a testing kit or something that's part of the in-kind contribution, has received a service that's within the scope of the grant, certainly any drugs associated with that service should be 340B eligible. And, that might mean HIV, Hep C medications may then qualify, for 340B pricing. The question then is whether drugs that may be unrelated to the scope of grant can qualify for 340B pricing. Is the individual still a 340B eligible patient with respect to drugs that are not related to services within the scope of the grant? And unfortunately, the guidance has not addressed this clearly. There are some FAQs and some informal guidance that can help, with a conversation about what makes sense for a particular entity, whether to use 340B drugs in a certain setting or not. But the government has not been very clear on this point, Emily. I don't know if you have other thoughts to share on that, because it's sort of been one of the age-old questions in the 340B space.
It really has. And I think, so one place we've seen sort of in the AIDS drug assistance programs in the Ryan White, they can cover almost any drug. There's some ADAPs that have a completely open formulary, and they're able to do that through the 340B program. So as Jeff said, the guidance is not great. I heard a really good analogy recently from the great Erin Fratto, who I should have also cited on some of my slides, but she's basically said, like, the 340B program is like trying to get into a club. And once you are in and you are a registered member of the 340B program and you're a qualified provider, what you order at the bar is up to you. So you might just want to stick for audits and simplicity state. You want to stick to just like ordering what you came there to order, but there is the possibility that you could order more things.
And, one example where this does come up, at least in the Ryan White space, which may not be as applicable for correctional facilities, but PrEP, Truvada is, for pre-exposure. But if your grant is for HIV infected individuals, that may limit your ability to use 340B for PrEP, because it's actually not within the scope of the grant. So that's an example of how this can come into play.
Thank you, everyone. That was great, a great discussion. I have a question that actually is more along the lines of hospital partnerships. And so perhaps, Jeff, this is a question for you. The question is, if a hospital is a 340B covered entity, is a telemedicine connection to the correctional facility adequate to extend 340B eligibility to that correctional facility?
Yeah, I mean, the answer is maybe, and unfortunately, this is another one where the specific facts and circumstances matter. So certainly, if you're interested in discussing offline, we could try to dig deeper into it, and I can see if I could be helpful. But as a general matter, the question is, in this scenario, the hospital is the covered entity. The hospital is the participant in the program. They have to meet the prohibition against diversion, so they may not fill a prescription with 340B unless it was for an individual who is a patient of the hospital. And the question is, through the telemedicine service, is the individual receiving the service a hospital patient? They may be. HRSA has acknowledged that telehealth, telemedicine is merely a mode of delivery. So it doesn't really change the analysis, and that, an individual can be a patient of a provider, whether they receive the service in person or through telehealth. So that may not necessarily be the barrier, but the question is, who is providing the service? Are they a hospital registered patient? Those are the types of questions that I think would matter to determine whether or not 340B could be used. So it's possible, but it certainly does depend on the facts and circumstances.
Great, thanks, Jeff. Another question about STD subgrantees specifically. So the question from the audience is, for those that are STD subgrantees, is there revenue to be made, or is the goal securing the lowest possible cost on a product?
So I think the answer is a little bit of both. Obviously, you want to be able to get the lowest cost for the product. That's going to make your federal grant dollars go further. However, if somebody that you are providing care for is eligible and has insurance, it is a good idea to bill that insurance. You'll receive more revenue, which is going to be invested back into the program. So you are able to stretch your scarce federal resources even further and provide care to more people.
Yeah, and this might, to some extent, depend on the certain laws about Medicaid and insurance in particular states. I can say in our state, when a person is incarcerated, at the moment of incarceration, they no longer have the ability to bill insurance. And so we, as the Department of Corrections, cannot bill insurance. That's also true of tribal entities. It's true of the Veterans Affairs Association. And it's also true of Medicaid, except for one small exception in our state. If someone is in the hospital for over 24 hours, we could possibly charge Medicaid. But for all intents and purposes, when a patient comes under our care, all of that care is paid for by the state. So our motivation for participation with our STD program and accessing the 340B pricing really is on the revenue, or I would say the intent falls in line with the intent of the whole law, which is to spread the dollars that we are granted as far as possible among this highly dense, vulnerable population that's with us. And then what should make those of you in public health salivate is that, we have this very dense, very large, high volume, vulnerable population at a time when in their life they are stable and are open to directly observed therapy. And that's really the selling point, higher on. So though the selling point, I think, is a financial one, meaning we are lowering the cost, it's really much more than making more or even breaking even. It's about how do we spread the dollars that we have more fully. And that's what I think brings these different entities together when it comes to the perspective from the Department of Corrections.
Great, thank you. This is going to be a question that's a little more in the weeds, but Brandon, I'm wondering if you could speak to what are some considerations or the options that folks should be considering in terms of these pharmacy contracts, as well as just general oversight of their program.
Yeah, so as far as pharmacy contract, if you already have a outside pharmacy provider, that's a natural place to look for kind of establishing a contract pharmacy relationship through 340B. As far as getting access to the 340B priced medications, that requires a wholesaler agreement, which we're happy to provide at no charge to our members. And that's something we routinely do. But it's something that has to be set up directly as kind of a three-party arrangement between the covered entity who is paying the bill and whoever gets the shipment of medications that's filling the prescriptions and that wholesaler itself. So it is sometimes a complex relationship, but it's definitely not one that's not insurmountable if you do need to go the route of a contract pharmacy.
Thank you. That's very helpful. And just for some broader context for the audience, how would you say that 340B generally compares to other drug purchasing options? Can you give folks just a little bit of insight into how things compare? And perhaps what other purchasing methods correctional facilities are using and maybe the pros and cons of those?
I guess I can jump on that one. We do also offer contracts that we've negotiated for city, county, and state entities that don't have the strict requirements of the 340B program. So that always is another option. 340B pricing, by and large, is statutorily mandated at those certain discount levels. So that is going to be, by and large, better than our pricing. There's a couple exceptions when things are kind of recalculating at the end of each quarter. So there's definitely some exceptions to that, but by and large, 340B is the lowest cost option available.
And Brandon's absolutely right that the prices are statutorily mandated. And so the formula really follows the Medicaid drug rebate program formula. And so for a brand name drug, you can expect the 340B discount price at a minimum to be 23.1% off of the drug's average price. Now that discount percentage can increase significantly beyond 23% because there's an inflationary penalty built into the formula. So if a manufacturer increases the price of a drug faster than inflation, price goes up really quickly, then they can be hit with an increased rebate amount or increased 340B discount amount. And so for some drugs, you can have very significant discounts in terms of the percentage off what the price otherwise would be. So it can vary, but for a brand name drug at a minimum 23.1%, generic drugs is 13%. But so for high cost Hep C, HIV drugs, I mean, it can be a significant discount off of a very large dollar number.
Thanks, Jeff. And I think that answers the question that just came through the chat, which was, how do covered entities access 340B or sub 340B pricing? Is it through the prime vendor, or do you reach out directly to manufacturers? So I'm not sure if there's anything else that you'd like to add to that, but I think what is stated has covered that question as well.
I mean, generally, and those who work directly with facilities and their purchasing may be able to speak to this better than I can, but just generally speaking, often, as a drug purchaser, you have a wholesaler and, you can set up a 340B account through the wholesaler so that the PHS, the public health service pricing is made available through that wholesaler purchasing account. There was also a reference in the question to sub-ceiling pricing. There is also a prime vendor program that is set up by statute. It's a contractor to HRSA. It's currently a Pexis based out of Texas. They negotiate directly with manufacturers for sub-ceiling prices below what the otherwise 340B ceiling price would be. And so sometimes, depending on the drug, there may be an option for that sub-ceiling price. But again, that should be made available through your wholesaler account. You can buy drugs directly from a manufacturer. I mean, that is in some cases, in one-off situations, an option that is available. I don't know if any of the facilities have, different kinds of purchasing practices that are, beyond the traditional avenues, but generally it's through the wholesaler.
Wonderful, thank you. I wanted to circle back to the question around what challenges Pauline or Robert, either of you have experienced, and specifically wanted to ask what challenges there might be around electronic medical records. This is a question that we briefly discussed in our planning call. And so Pauline, I didn't know if you wanted to elaborate a little bit on some of those challenges.
Yeah, so we have an electronic medical record here in Rhode Island, and we've been electronic since 2009. So part of the challenge there is creating template changes on the fly. So all of a sudden, if we want to add 2 or 3 new questions about anything that's sexually transmitted related, it then has to take several layers of trying to get people's approval and make the change. And so that's been a bit of a challenge for us. Fortunately for us, we have a super user group that have no problem training other people on how to do it, but then creating those reports that you can then run on a weekly basis to see who's your new patients, have you added anybody, who are the patients that have finished their fiber scans or diagnostic tests. That part of it is easy once you've got the data built in, but the challenge is getting people to fix things on the fly. Dr. Lawrence, have you run into that as well?
Yes, maybe in a related way. The key is being able to document what you've done so that when you go back to say, are we appropriately applying the program, being able to quickly pull a report. But to do that goes all the way to the front user to say, my provider who sees the patient on the front line or the nurse has to document things appropriately. So the challenge on our side is we do an STD screen of sorts for every single person who comes into the facility. But just like in Rhode Island, our correctional facility is both a jail and a prison. So there may be individuals who come in and they are not in a position when they first walk through the door to even be ready for that kind of screening. Well, it can be put off, or the nurse, would say, well, I asked the questions, but they refused. I think there was a question in the chat box earlier. What happens if somebody refuses the testing that's offered? Well, we still offer it to every single patient, but there are times when they may refuse to answer. And in our EHR, that doesn't generate an answer, which means it's not even documented that you asked the question. And then when you go back to do the report, if this person later, was found to be eligible, let's say for 340B, I have a hard time tracking back to make sure that those questions were asked or that they received the services in kind. That's just one example. But the challenge has really been, as Pauline correctly points out, that you really have to think through, to some extent, the weeds that have to be there. I mean, you're not trying to grow weeds, but to some extent, you got to really get into the details. And once you decide, okay, we're going to access this priced med, that's probably the easiest part. The hardest part is just making sure that the program's implemented because it requires more than one person. So many people have to be working together in concert. And I would say that's the challenge. From the EHR, that's just one component, is remembering that individuals on the IT side, the people who are involved in running our EHR, that they're fully involved from the beginning, saying how are we going to document what we're doing.
Yeah, one other thing that we ran into, and that fairly recently, was the physician ordered the med, but the patient hadn't been registered in the STI clinic as of the date the med was ordered. So unfortunately, that didn't go through 340B. And then in order to have the next 28-day supply, you need a reorder, a brand new order. You can't just piggyback onto, it's just a refill. At that point, you have to actually do another order for the medication for it to show up as a 340B.
I believe as of right now, we have answered all of the questions from the audience and made it through all of the questions, the more general questions we wanted to ask. So if there, one more question that just came through, and that is, do we know what percentage of state prisons are currently accessing prescription meds via 340B entities? Do 340B entities need to be located near correctional facilities or have staff at the correctional facility in order to be able to use 340B?
I would just say, and those who are on the panel may know about colleagues of theirs in other states that are using 340B. And so certainly I think that networking is often a great way to learn more about, who else is using the program. I don't know if there's a data point out there on that, but I do know that there is a publicly available database that lists all the 340B covered entities. So certainly you can see correctional facilities that are registered in the program, if by name they're listed. So that is a publicly available way of finding out what state correctional facilities may in fact be current participants in the program. And to the second question, I guess the question is, if the correctional facility itself is participating in the program, whether or not they need to be providing the services directly at the facility. I'm not sure if that's the question. I think the answer is, it depends on if this is a hospital partnership versus if the correctional facility itself is participating in the program, but it's meeting the eligibility requirements, and then it's meeting the 340B patient definition test. And there's no one way to do it, but those are the tests that need to be met. The location of who's doing what, I think you need to evaluate as part of those two tests to figure out if you're meeting the requirements or not.
I can kind of piggyback on that as well. Just kind of an unscientific survey. I would say maybe close to 40% of state correctional entities access 340B in one way or another. Obviously, it's a spectrum of just a handful of medications versus the whole spectrum of pharmaceuticals, but it does really run the gamut from one facility to another. I would say maybe close to 40% nationwide. And that's on the state side of things. Local correctional facilities, individual counties or jails, I would say that number is probably much, much lower, just based off of the length of stay for an average individual. And then location for correctional facilities, really you can utilize a prescription filling arrangement with a pharmacy halfway across the country as a mail order thing. It doesn't necessarily need to be in close proximity. It's more about that communication back and forth.
Awesome. Thank you, Brandon. Thank you, Jeff. Any final questions from folks? Please do enter them into the chat as we are coming up to being close on time. There's another question that was just submitted. Do private prisons in states that have 340B affiliations qualify for the same pricing?
I think it goes back to the same eligibility question in terms of whether it's a government correctional facility or a private prison, but do they have funding that they're receiving from the STD grant recipient, whether directly or through some sort of in-kind contribution? That's the nexus that is required for eligibility. So if in fact there is a STD grant recipient that has a program in place with a private prison, then there may be the potential for that. But that is, I think, the key question.
Awesome, thank you. As we begin to wrap things up here, I just wanted to pose a final question to the group and also give you an opportunity to share any last thoughts that perhaps we didn't touch on already that you think it's important for the audience to know. So the question that I'll leave each of you with and ask each of you to answer is, what advice would you give to a correctional institution who is considering implementing the 340B program? So any final words of wisdom that you'd like to share, and we'll just go around the Zoom room. So Emily, would you like to start?
Sure. Sorry, I am having internet issues today of all days. So I'm gonna, if you could repeat the question, it kind of was breaking up.
Yeah, no problem. Any final words of wisdom that you'd like to share with folks that are considering implementing the 340B program in their facility, or any final words in general that you'd like to leave folks with?
That was a lot easier than I thought I had heard, so that sounds great. So yes, I think it is use your resources. As Pauline already said, Jeff is an amazing resource, but the other panelists here are also really great. There are people that have done it before that can talk to you about the ups and downs. Talk to your health departments. They've worked with a lot of different subgrantees and people are really excited to be doing this. So I think that is sort of the best advice is learn as much as you can, but never be afraid to ask questions.
Thank you. Pauline?
I would say probably the most important thing would be having well-written policies and procedures so that you can always go back and reference them. If you have a question, you have a change in leadership, you have a change in staff, if you can go back to those documents, it's really a lifesaver.
Brandon?
I guess my probably take-home message would be start low and go slow, which is kind of the motto in a lot of things. If you're just starting off with a handful of medications or one or two disease states that you're really kind of closely tying the eligibility criteria to, I think that's going to be a lot easier to get up and running as opposed to going full tilt on it.
Robert?
Yes, thank you everyone for joining. I think the parting comment I would make is just to say, regardless of whether or not you're working in a state where this is a easy thing to implement, or if it's a state where this is a long, slow slog, in either case, the end result is worth it. We are entering into and are in the midst of an economic eye of a storm, so to speak, when it comes to hepatitis C. Hepatitis C is one of the defining illnesses of our generation. COVID aside, if we don't jump on eradicating Hep C when we have an opportunity to at this time, all the modeling shows that it will become exponentially expensive in the decades to come. And that, as you know, already overwhelms your state systems. It will bankrupt systems if we don't take care of the opportunity that we have before us now. 340B is just one component in taking advantage of this opportunity, so to speak. And I think that you'll find, even if you don't achieve the final goal as you anticipated in the beginning, the relationships that are built and the questions that are brought to light are so important that at the end of the day, you'll find that this was time very well spent trying to figure out how to implement the 340B program. So I think that would be the final word is don't get discouraged. This fight is well worth being a part of.
And last but not least, Jeff.
Thank you for everyone joining today. And I would echo the other panelists and, in particular, Dr. Lawrence's point that the benefit is well worth it. And it very well could be, and it probably is. But I also think, as others have said, taking the time and putting the legwork in advance so that you're going into it eyes wide open is really important. Often in my legal practice, I'm working with providers and covered entities after the fact when they get the audit request, and then they find out that they were not doing things in a compliant manner. And you don't want to find yourself in that position. So I think in order to make sure you're able to access the benefit, which is an important benefit, spend the time to make sure you know what you're getting into, that you're putting your policies and procedures in place, that you're following those policies. The records that you produce through your EHR are incredibly important. So you have documentation to show the auditors that you're doing things in a compliant manner. So I think it's just really important to take the time before you actually start purchasing drugs at 340B pricing so you can implement a program that you can feel good about.
Awesome. Thank you so much. I am just super excited that you all were able to spend some time with us today. I want to first start by thanking all of our wonderful panelists for sharing their time and wisdom with us. We hope that this was an enlightening session for many of you, and that you got some good information to take away and maybe some questions to continue pondering after the session. I also wanted to thank each of you that tuned in today, recognizing that everyone's schedules are very, very busy and they don't seem to be getting any less busy. So thank you for spending some time with us. I just wanted to share a couple of last thoughts regarding some upcoming events that both NVHR and NHCN have coming up. So I'm going to share my screen again with folks. And just wanted to make you aware of a couple of opportunities to continue engaging with both the National Hepatitis Corrections Network as well as the National Viral Hepatitis Roundtable. Next Wednesday, April 7th, the National Hepatitis Corrections Network will be hosting a spring networking event. It'll be probably a great opportunity to meet some of the folks that are attending this webinar today. So attendees will meet with fellow correctional health professionals who are working to address viral hepatitis. This event is also designed to mimic the critical and underappreciated conversations that happen in between these presentations and in between presentations that happen at the annual in-person meeting, which, as you can see, did not happen this year due to COVID. It's typically held in March. So do tune into that if you are available. Activities will include both networking through regional professional breakouts and certainly plenty of opportunities for some more one-on-one connections as well. Also wanted to just highlight that on Thursday, April 15th, the National Viral Hepatitis Roundtable will host its monthly grassroots advocacy call. And so these calls are an opportunity for community members and public health partners to learn about updates in viral hepatitis advocacy, as well as to share any progress or challenges that are happening in your jurisdiction. So we hope that you'll join us for either or both of those events. Registration links for both events will be available in the chat box and also can be found on the NHCN and NVHR websites. Any final questions from folks? I don't see any in the chat. All right. Well, thank you all again so much again, and a special thanks to our panelists. This was a wonderful presentation, and we look forward to connecting with you all soon. Thank you so much.